Hi, everyone. I'm Carol Fleck, and on behalf of the ADDitude team, I'm pleased to welcome you to today's ADHD Experts presentation titled OCD in Children with ADHD, Navigating the Dual Diagnosis. Leading today's presentation is Natalia Aiza. Natalia is a therapist and the co-founder of Kairos Wellness Collective Anxiety and OCD Clinic. Obsessive compulsive disorder, or OCD, is characterized by obsessive thoughts and impulses, which can lead to repetitive behaviors. Now, this might surprise you, but for many people with OCD, it's not about a fear of germs and endless hand washing. It's more often about avoidance. A child may feel panic and anxiety because they fear peer rejection at school, for example, and that leads to school avoidance. Studies show that nearly 1 in 4 children with OCD also have ADHD, but identifying and treating this dual diagnosis can be tricky because the symptoms of each condition may conflict with the other. This can be confusing for parents, educators, and others. In this webinar, we will learn how to identify and support children with OCD and ADHD. Natalia will also address specific problems that were submitted by a few folks in advance of the webinar. We'd like to begin today's webinar by asking this poll question to our live audience. In what way does your child experience or express their OCD symptoms? Please select your answers and comment in the text box under the video player to tell us more. For answers to common webinar questions about slides, transcripts, and certificates of attendance, click on the FAQ tab of your webinar screen. If you support the work we're doing here at ADDitude to strengthen the ADHD community, we encourage you to visit additudemag.com/subscribe and sign up for ADDitude magazine. Our annual Success at School issue is out now. Leading experts offer advice on how to boost your child's executive function skills, how to implement behavioral interventions in an IEP, how to help students plan and prioritize, and so much more. So sign up for ADDitude magazine today for yourself or to share with a teacher or a loved one who could benefit from greater ADHD understanding. Click the magazine tab on screen to learn more. Finally, the sponsor of this webinar is Accentrate. Accentrate products contain omega-3s, vitamins, and minerals in their active forms to address nutritional deficiencies and support your mental health. These supplements provide brain-ready nutrition and support attention, focus, and emotional balance. Click the link on screen or visit phoenixhealthscience.com to learn more. ADDitude thanks our sponsors for supporting our webinars. Sponsorship has no influence on speaker selection or webinar content. So without further ado, I'm so pleased to welcome Natalia Aiza. Thank you so much for joining us today and for leading this discussion.
Hello, I'm so happy to be here. Before I get started, I just really want to thank Carol and ADDitude Magazine because I have been so thrilled with their content over the years. I could not have really navigated my daughter's ADHD diagnosis without the incredible resources on this website. So it's a full circle moment for me to be speaking with you today. So as I hinted at, I am a parent of ADHD. I am a person with ADHD. And also in my family system is a lot of OCD. So this is a very personal topic for me. I am an OCD clinician now, but I actually started as an ADHD specialist. So I understand what it's like to really understand the ADHD piece and not actually have that OCD knowledge. So I'm super excited to kind of introduce you to just a little bit of what I have learned running Kairos Wellness Collective. So as Carol said, shockingly, 25% of kiddos with OCD also have ADHD. This is a huge concurrence in the mental health world. This dual diagnosis is considered to be quite common. A lot of practitioners actually believe the concurrence rates to be even higher. Both ADHD and OCD come genetically, and so we'll see these very neurodiverse family systems with different iterations of ASD plus OCD, ADHD, plus anxiety, or ADHD plus OCD. And so parsing out what actually is happening is incredibly important. So a lot of kiddos are coming into my clinic already having their ADHD diagnosis. I think as a society, we've gotten much better recognizing that early, getting treatment. However, we're not that lucky in the OCD world. Most therapists do not understand OCD. And I say this as a therapist that used to understand nothing about OCD despite having it. So I get lots of well-meaning parents saying things like, how could my child have OCD? Their room is a mess. Or how could my child have OCD? They lose everything. Or my child isn't careful. Or my child's a risk taker. Or my child is always trying to get out of school. Aren't kiddos with OCD like really into school? These are all stereotypes and cliches. And again, it's based on what we know as a society about OCD, which is unfortunately not really accurate to the experience. So OCD is a cycle. It's not a personality. We hear so much online, I'm so OCD, or look at this OCD moment. OCD is something that can actually be incredibly debilitating. If you hear someone talk about OCD as their superpower, they're probably not actually experiencing OCD, because those of us that really have it, it can and will hijack our lives if we don't seek treatment. So OCD is a cycle, which means it starts with an intrusive thought or a fear, an obsession. When we have that intrusive thought, we then give it meaning. So I might have the intrusive thought, which I did a lot as an ADHD child, of I am stupid. When I have that intrusive thought, I then give it meaning. I say, well, I thought that, therefore it must be true. And then I cycle into anxiety, disgust, distress, and I do compulsions to alleviate distress. So one of my compulsions as an unmedicated ADHD child was actually to reread everything 3 times. I did this with every single textbook starting in high school. And yes, it was temporarily helpful. When I knew the answers, I got short-term relief. However, the fact that I believed that I needed to read everything 3 times was a negative reinforcement of my obsessive, intrusive belief that I was stupid. So OCD can be a mental compulsion. It can be a physical compulsion. But a lot of times with ADHD, it's actually mental. So on the left, you'll see something that my own daughter actually drew. She has ADHD, inattentive type, and OCD. And she showed how an intrusive thought gets amplified by imagination, becomes a whole what-if story, leads to the compulsion of rumination and the desire to fix whatever it is that she's worried about, and then a ton of negative emotions. However, as she says, on the outside, I just look like I'm zoning out per usual. She really helped me understand how inattentive type ADHD can have so many mental compulsions that happen that are going under the radar. All right, so what does pediatric OCD actually look like? It's not hand washing. I mean, there are some cases of hand washing, but I will tell you it is the minority of the cases I see, even after COVID. If there is a fear of contamination, I see it present more in desire to wear a mask or a desire not to leave the house. So OCD has different themes. You don't necessarily have every theme. In fact, you probably don't, but you most likely have 2 or 3 of these themes. One is the harm theme. These are the kiddos that are stalking you on Life 360 instead of the other way around. These are the kiddos that are over texting, over calling, worried that you're in an accident when you don't come home right on time. The fear of harm to loved ones or fear of harm to themselves, that is a very common OCD theme. I would probably say the most common. There is the people-pleasing theme, which is the kiddos that are like, are you mad at me? Do you still love me? The kiddos that are worrying that their friends are going to reject them. These are the kiddos that will actually over-apologize as a compulsion and over-accommodate other people's needs. So with ADHD, we make mistakes, as all humans, but maybe extra. However, with the people-pleasing theme, our tendency is going to be to say, oh my gosh, I'm so sorry I lost that thing. I'm so sorry I forgot this. And to really go over the top in trying to sort of make other people not upset with them about their mistake. There's a time theme as well. This is time in terms of timeliness, but also the passage of time. There can be a deep fear of regret in OCD kiddos and a fear that, if I don't do this thing, I'm going to regret it forever. This is my only opportunity to be a child. A lot of dysregulation as well when plans change. So this is the kiddo that seems chaotic, but then will be asking you, well, what's the plan for today? Where are we going? And if you change your mind, they will get upset. Separation anxiety, this isn't just separating from parents. This is a fear of sleeping alone, which I've seen in, up through high school, fear of parents traveling without them. These are the kiddos that are developmentally ready for sleepovers or stay away camp, but they are refusing because they are afraid that something bad will happen to them or to their parents during separation. Right. Then there's the perfectionism theme. This is a huge one with the ADHD kiddos. Remember that perfectionism isn't just being perfect and overachieving. Perfectionism can also show up as inaction. Perfectionism can show up as not doing activities, quitting them because we're not great at them. There is a strong fear of failure, both in ADHD and OCD, and a lot of reassurance seeking that we did well, we did good enough. Then there's the health theme. This is the kiddos that are afraid of very adult things like aneurysms and cancer. They are constantly worried about getting sick. The health theme among kiddos escalated tremendously, as you can imagine, during COVID and right after. And another neurodiversity classic theme is the food theme. So these are the kids that have extreme food pickiness. I've actually seen extreme healthy eater children, quite a few of them, who are worried that something bad will happen to them if they don't eat these certain foods. This is kiddos that can't eat the same food as their parents, and not due to real allergens or other, actual digestive issues, but rather because of the fear of allergens or the fear of digestive issues or the fear of something bad happening. And then finally, the classic that everyone knows about, the contamination theme. So this isn't just excessive hand washing. It can be, it often is, but it's also about an excess of routine in hand washing or decontamination. So it doesn't necessarily mean they're washing their hands for 30 minutes, but for example, they might be washing their hands while singing the alphabet song. And if you say something to them while they're doing it, they have to start over at A. These kiddos tend to see their beds as a contamination safe space and have a lot of problems with other people being in their beds. They can also see certain humans as clean and others as dirty. The most common presentation I see of this is little brothers, poor little brothers. They get pegged as contaminated by their older sibling, and then they actually are phobic of their own sibling. All right. So OCD can be misdiagnosed as ADHD. I see that all the time. It can also be missed entirely when ADHD is present. ADHD and OCD actually have a lot of similarities. It's abnormal brain activity in the frontal striatal system. This is opposite, but always in the same part of the brain. So it is overactive in the case of OCD and underactive in the case of ADHD, but in both it's affected. Executive function is affected with both. Problems with task switching, delayed gratification planning, that is all very common in both OCD and ADHD. However, the OCD executive function issues are actually attributed to something called executive overload theory, which just basically means there is an overflow of thoughts, worries, mental compulsions, and you just don't have room for the day-to-day things that you're supposed to be paying attention to. Attention difficulties. It's very difficult to pay attention when you're worried about dying or vomiting or your parents dying or something horrible happening. So you tend to, with OCD, be distracted by your own thoughts, distracted by your own worries. So people with ADHD and OCD, they both struggle with impulsivity. So someone with OCD, they might actually impulsively do their compulsions. There's some difficulty with self-control, again, difficulty in resisting compulsions, inhibition, and difficulty in seeing kind of far into the future. Even though people with OCD do worry about the future, they are actually very present-minded because they are very afraid of something terrible happening right now as well. Right. So these are just a few of the most common ways that I see OCD show up pediatrically in neurodivergent children. And this is focused on ADHD. However, I would like to just make a shout out that there is a big concurrence rate with ASD. And for those of you whose kiddos meet the criteria for all three, I would like to direct you to the work of Dr. Megan Neff. She is absolutely pioneering in understanding ASD plus OCD. So school refusal and school avoidance, that is a very, very big symptom of OCD in neurodivergent children, especially if there's learning differences. The concept that school is unsafe, it's a place where we might have panic attack, it's a place where we might feel like a failure, and home is safe. It's a place where we don't feel that way. We aren't experiencing all this anxiety. And then it reinforces this cycle of, well, I am better, I feel better when I'm at home, so I'm going to try as much as possible to stay home. People pleasing and compulsive apologizing, I addressed that one earlier. It is related to a fear of making mistakes, and honestly, it's a form of masking for some of us with ADHD who have trouble, admitting that, my short-term memory, not great. If you want me to do something, you can't ask me verbally, which I now can say straight up to everyone in my life. But as a child, I really couldn't. I was trying to pretend that I could verbally process and did have good short-term memory. Emetophobia, for whatever reason, this is the it phobia. I don't know how it relates to ADHD, but the fear of vomiting is the number one phobia that I see among kiddos right now. Misophonia, this is one of those that relates a lot to ASD as well. This is common when the child has a sensory sensitivity, a sensory sound sensitivity, and a disgust trigger. So this is basically a phobia or a disgust with the sound of people chewing, which leads to these OCD kiddos eating lunches away from other people or asking their family members to, not be in the room when they're eating. Social phobia, this is huge. People with OCD tend to have an extreme fear of embarrassment. The idea of blurting something out is actually an OCD fear. And then with ADHD and some impulse control around saying things that are on your mind, this can lead to a avoidance of being in social situations where you might make that kind of mistake. And then finally, this is another big one. This could be its own webinar entirely. It's body-focused repetitive behaviors, otherwise known as BFRBs. This is nail biting, skin picking, pulling out eyelashes, and other hair on the body. So BFRBs, and again, we don't know a lot about the neurology of these disorders. The science is still emerging, but BFRBs, for whatever neurological reason, are highly, highly correlated with ADHD. Some scientists believe it has to do with a difficulty with impulse control, plus the dopamine release of, the little bit of pain and pulling out an eyelash. However, I see body focused repetitive behaviors in many, many of my clients that have the dual diagnosis. I will address this again later, but this issue is incredibly important when we're talking about stimulants. All right. So how OCD and ADHD affect a child's ability to access the curriculum. As I mentioned before, chronic absence from school is endemic when there is a concurrence of OCD and ADHD. There's those kiddos that feel like if things aren't just right, they can't go to school. There are the kiddos that have a fear of contamination at school, fear of embarrassment, failure, all the things that I had mentioned earlier. But well-meaning parents might allow them to stay home because school is really exhausting for a neurodivergent kiddo. Like, I know. However, when we are allowed to stay in a safe space and not pushed to face our fears and face our anxiety, what ends up happening, unfortunately, is that we actually start to associate home with safety and school with panic. And we actually lose some of our distress tolerance. So the kiddos, the second main way I see OCD and ADHD affecting ability to access the curriculum is attendance, but you're not all there. You are in your own OCD world. Like my daughter's chart, it is looking like ADHD, zoning out, but actually a child is withdrawn due to the complexity of their OCD and how overwhelming it is to be in a school environment. All right, so this is probably the most important slide of all. How do we treat ADHD plus OCD? So the absolute number one, hands down, most helpful treatment is exposure response prevention, ERP. ERP has some incredible results. I think it's like 80 or 90%. They're still studying it because not everyone applies ERP correctly. However, when applied correctly with an OCD specialist, this type of therapy works. It is basically a systematic desensitization to your fear triggers. It is only done by OCD specialists. And so the IOCDF, the International OCD Federation, has a list of ERP trained clinicians in your area. You can also email me and I can try to connect you with one. But we are lucky because unlike other mental health issues, our therapy, ERP therapy, works for our disorder, for OCD. Pharmacology, we're also very lucky in this respect. The medicines out there do really work for OCD. Most commonly, we will see an SSRI, usually Zoloft or Prozac for the littles, and sometimes an augment of a low dose of an antipsychotic, often Abilify for the neurodiverse kiddos. These OCD medications can and should be used in conjunction with ADHD medications. They can work with stimulants. I myself am on a stimulant and an SSRI for my OCD and ADHD respectively, and I have been able to find my balance pharmacologically. Also helpful, ICBT, ACT, and DBT. However, I really want you to make sure that the clinician that you're choosing mostly does exposure response prevention, because that is where the science is. Now, very, very importantly, treatments to avoid. I hesitate to say this online because I get a lot of blowback, but it is completely true. Talk therapy is completely ineffective for OCD. Talk therapy actually can make OCD much worse. And the reason why is that talk therapy can elevate your emotions. It can give you a space to vent and almost amplify and ruminate out loud with your therapist. A lot of times the therapist becomes a compulsion in a person with OCD if they are simply talking about the stressors. Talk therapy, like there's different levels of quality of talk therapy, but for OCD, the evidence is clear. It does not help OCD. Another thing to really avoid is an ADHD expert with no OCD training. That doesn't mean that you shouldn't use an ADHD expert for your ADHD, but just know that unfortunately, the OCD part is not going to be handled by the ADHD expert, and you really do need a second specialist. Same thing with psychiatrists. The medication of ADHD plus OCD is actually complex. I kind of simplified it on the other side, but you want someone that is aware of how stimulants can actually uptick OCD symptoms and BFRB symptoms, body-focused repetitive behavior. So you want a psychiatrist that is not afraid to actually utilize stimulants with someone with OCD and ADHD, because some of us really need them to function. However, knows to trial them separately and also knows how to augment the OCD meds in order for the child to be able to continue to take their stimulants. All right, and I'd like to end with a case example. This is Nadia, age 7. So Nadia has always been a worrier. She has trouble separating from mom for preschool, difficulties with raising her hands, speaking out loud, fears of sleeping alone. Family members describe her as lost in her own thoughts. She sometimes will seem to be in an imaginative world, but then she looks up in panic to make sure mom is still in the room. In the first grade, she was beginning to fall behind in her learning markers. Her family takes her in for a neuropsych eval, which diagnoses ADHD, inattentive subtype, and GAD, generalized anxiety disorder. The recommendations are Focalin and talk therapy, but after implementing these recommendations, Nadia only seems to be getting worse. And now she has mystery stomach aches every morning before school and asks to stay home. She isn't advancing academically, in part because of frequent absences, and seems more distracted than ever. So Nadia is not an actual client. She is a composite of many clients that I see come into my center who are not getting better despite having done the big neuropsych eval, despite having started medicine. The reason why I would say this composite, this case of Nadia is not getting better, is that she most likely was misdiagnosed with generalized anxiety disorder and actually has early onset OCD. So there are all these markers of OCD, but a child that started out with being able to separate well from parents, but began to have more and more difficulty, has markers of social phobia, has a sort of overly developed worry profile. These are all very strong indications that OCD might be at play. So if Nadia comes into my office, the very first thing I'm going to do is a parental assessment for OCD symptomology, and I will give Nadia the SciBox, the Children's Yale Brown Obsessive Compulsive Disorder Screener. It's a pretty simple tool. It's available free online. When we go through all of the different categories of worry, it will probably become clear that Nadia has certain themes and that there are obsessions that are deep and underlying the behaviors. So Nadia would need treatment with an exposure response prevention specialist, and she most likely would either want to hold off on the Focalin and focus on treating the OCD, or concurrently treat the ADHD and go on an SSRI to just help her be able to access her life. I want to show you in conclusion some drawings that one of my clients made for me. She was trying to navigate a recent trip to Sephora that felt very activating in different ways. And she was describing how on the left, it was activated because of ADHD. Oh, I'm so excited. I want the whole store. I want this and this and this. That ADHD joy in Sephora. But at the same time, it was activated on her nervous system by her OCD because she kept having intrusive thoughts that her mom was going to leave her there, that her mom was going to be disappointed in her. And as she drew there, her brain was screaming, no. Her ADHD was like, buy this. And her brain was screaming, that's not a good idea. Something bad is going to happen. You're going to disappoint your mom, or she's going to leave because you're being so extra. As my client described this one trip to Sephora in these complex ways, I just had this pang of intense compassion for the kiddos that are navigating both ADHD and OCD, because it is complex for adults, and I would imagine truly overwhelming for the kiddos. So thank you so much for being here with me. Thank you for letting me speak about this topic that is so important to me. And please send me an email at natalia@kairoswellnesscollective.com if you have any need for clarification, any additional questions. I'll pass it back to Carol.
Thank you so much. And that's very generous of you to offer your email. And thank you for such an important and informative presentation, Natalia. We really appreciate it. Before we start the Q&A, I'd like to thank Accentrate once more for sponsoring this webinar. I'd also like to share the final results from today's poll question. We asked, in what ways does your child experience or express their OCD symptoms? Here's what you said. 26% said body-focused repetitive behaviors. 20% said school avoidance or refusal. 20% said people-pleasing and compulsive apologizing. 19% said social phobia, and 11% said misophonia. So, yeah. Now let's move to the Solve My Problem portion of today's event. Natalia will address specific scenarios that were submitted by you, our listeners, excuse me. So one ADDitude reader said, clothes and shoes are a huge trigger in the mornings before school for my 6-year-old. Nothing feels right to her, and it's caused major meltdowns, even when she wants to wear these clothes. It's as if she wants the clothes to fit perfectly every day, and that's not the case, even when she's worn them before and they were fine. Any advice on helping her process through the OCD and perfectionism, which could be a result of anxiety about having to hold everything together for 8 hours at school?
Thank you so much for this question. It's a great one. Most likely my fictional character of Nadia is experiencing this as well on her way to school. So I want to preface this with just a big picture thought that I am not getting the full story when I'm answering this question. And there are so many follow-up questions that I would love to ask you, the listener, but I can't in this format. So I'm going to do my best with the information that I have. But I would say with this kiddo, the most important thing is for her to increase her distress tolerance. So when we have OCD and ADHD, our window of distress tolerance, it can get quite tiny. And especially when we have a highly empathetic parent that is always trying to help us, feel more comfortable, we actually need to be pushed to sit with the discomfort. So if I had your child in my office, I would actually introduce her to the game of just wrong. And so we would put on two mismatched shoes. We would put on different socks with the seam in the middle. We would sort of practice sitting with the discomfort of something not being just right. And it is painful. And in the case of ADHD, and perhaps this child might have more sensory issues going on, perhaps ASD, perhaps like a sensory processing disorder that's sort of compiling that sense of distress with clothes and shoes. We have to be compassionate, but also encouraging and supportive that the child can, in fact, sit with the discomfort of something not feeling good.
Okay. Another ADDitude reader asks, do you have any creative ideas to help teens who've spent nearly a decade shutting down over their diagnoses and largely refusing to acknowledge or accept treatment? My son will spend days in anger if the idea of medication or therapy is raised. Every kind, compassionate, creative, logical route imaginable has been tried. The few times we've managed to get him to have a conversation with a clinician, he spends the hour with a sweatshirt over his head. Zero interaction. He's lost so much of his childhood and now adolescence to untreated severe ADHD and anxiety, alongside modest OCD symptoms plus explosive anger. What can we do?
Well, so first of all, hugs to you, family member that submitted that. I can hear the love and the effort in the question, and I understand the frustration that you're feeling. I myself have a kiddo that refuses therapy, and I run a big therapy center. So like I absolutely have like been in that position, and quite honestly, I was that kid. So when I was a teenager or a child, actually, I never would have accepted my diagnoses, therapy, or medication. I just would not have. I preferred suffering because to me that meant that I could still be in denial of my mental health disorder. That was sort of my experience, that oppositionality, that anger, that was me. And really, it was adulthood, kicking my butt a little bit, that helped me like really self-motivate to seek treatment. So what I would suggest for these parents is to look into Dr. Ellie Leibowitz's program of SPACE. It's supportive parenting for anxious childhood emotions, I think is the acronym. He is based out of the Yale Child Study Center. You can look at spacetreatment.net to see a list of providers. I do his treatment with parents whose children are refusing treatment. There's actually a lot that you can do as parents that can maybe reduce some of the accommodation, reduce some of the power that the anger has in the family system. Because what ends up happening when we have a child that's suffering, but also externalizes with explosive anger, is that everyone ends up tiptoeing around their anxiety and OCD. And we definitely don't want to do that. That actually empowers and enables the avoidance cycle. So that would be where I would start for sure with the parental interventions.
Okay. Another ADDitude reader writes, my daughter has a variety of sleep routines that she has to follow to be able to go to sleep. The problem is that they keep getting more elaborate and lengthy. How can I set limits here while still enabling her to feel safe at bedtime?
Yeah, this is a great question and so applicable to so many kiddos. So a lot of us, our OCD gets way worse at night. There can be fear of the dark, fear of an intruder, fear of someone dying in their sleep. There's a lot going on in the psyche at night. So what families end up doing is creating these lovely bedtime rituals, which unfortunately the OCD hijacks and snowballs. So that's the thing with OCD. I cannot emphasize enough that something good like like praying or meditating or hugging your parent and saying, I love you. Anything positive can be warped, exaggerated, and turned into an extreme version of itself by the OCD. So you will see kiddos, repeating I love you, and then when their parent doesn't say I love you back in a just right way, they have to start again. These kiddos are trying really hard to feel safe, but unfortunately the compulsions, the rituals that they're doing to feel safe are actually long-term reinforcing the fear. So when I would work with this family, first of all, I would ask the parents, both parents, to really align with the goal of reducing the bedtime to a manageable amount. The reason why is, for everyone's sanity, but also because elaborate sleep rituals often actually lead to insomnia, because you are reinforcing this concept that nighttime is dangerous. I would definitely work with the parents utilizing space treatment, which I mentioned before, around bedtimes, because we can't stop the child from ritualizing, but we can stop ourselves from participating in the ritual. And finally, I would just point out that this is a common misconception about safety compulsions. It seems to people on the outside that it makes us feel safer. It only does so temporarily. So any sort of ritual, whether it's checking a lock, whether it's, a good night book, any compulsion will only allow us to feel better temporarily, but you will see it escalate over time.
Okay. Our last ADDitude reader submitted this. My daughter has ADHD and a lot of intrusive thoughts that culminate in disordered eating, skin and nail picking, and self-sabotage. We had her tested for a lot of things to understand how her brain works, and OCD wasn't mentioned, although we've always thought she had that tendency. Would an official diagnosis of OCD help or not?
Yes. I love that I got this question because it allows me to get on my soapbox of yes, the OCD diagnosis matters. It matters so much. It matters for the treatment of the disordered eating. It matters for the medication. It matters for the therapist you choose, and it matters for the dose of intervention, which means how much intervention. Is an IOP needed? Is a PHP needed, or just outpatient? So getting an OCD diagnosis, and I wish it was that easy that we could mention OCD to a psychiatrist, or better yet, they mention it to us as something that they're ruling out. But the unfortunate fact is that most therapists and even a lot of psychiatrists and primary doctors really do not understand OCD. And that's not my personal opinion. This has been well studied by the IOCDF. In fact, 50% of primary doctors have missed OCD, misdiagnosed it. It is actually a very big problem in the mental health community that many of us working in this field do not actually understand what OCD really looks like. After doing this webinar, y'all are going to know more than a lot of mental health providers about OCD. That's sad and it's bad, and it leads many people to come into my office after having seen dozens of providers and say, no one mentioned OCD. How is that possible? So all that to say, I want you to find an OCD specialist to run the SciBox, which is that OCD diagnostic that I mentioned. I will say that with disordered eating plus ADHD plus intrusive thoughts and additionally a BFRB, I would be very surprised if your child did not also meet the criteria for OCD. Those are all very clear flags that OCD should be in the running at the very least. And that will completely change the treatment. So as some very early advice to give you, I would definitely look into whether the disordered disordered eating might actually be ARFID, avoidant restrictive feeding intake disorder. This is a type of disordered eating that is quite common in the neurodiverse community and the OCD community. This is a type of eating disorder that's not necessarily about the body, but it is about the way the body feels when it eats. It's also based on phobia of food. So I would definitely evaluate for ARFID, and then I would also find a psychiatrist that understands BFRBs because, as I mentioned before, ADHD medication stimulants can actually make skin picking, hair pulling, nail biting much, much worse. I myself have to stay out of, sight of mirrors when I'm on my ADHD meds because I know that I will start picking at my skin if I have that opportunity. Once the stimulant wears off, the desire to skin pick drops off a cliff. And that is an experience that a lot of kiddos and adults have. Again, it's not a reason not to take the ADHD meds, but it's certainly a reason to look into other treatments. There's also a supplement, a vitamin called NAC, which is commonly suggested for cases of body focused repetitive behavior. This is a vitamin that helps curb the intense habit, but also working with a therapist that understands all of these different issues and how they work together.
Okay, thank you, Natalia, and thank you to everyone who wrote in. Now let's turn to your questions from the live audience. The standard approach to OCD appears to be exposure therapy, which you addressed. Could it be that this standard approach doesn't work for autistic brains? Someone asks.
Yes, thank you so much for bringing that up. So, as a side note, I am surrounded on all sides by just wonderful ADHD and autistic family members, my partner, my son, my brother, my father. I am incredibly against ABA therapy, and I realize that ABA therapy might sound a lot like exposure response prevention to the layman. So let me sort of explain how it's different. So when you have a kiddo that has autism and OCD, you have to really, really, really know what lies in each diagnosis. So, for example, the kiddo with Just Right, with shoes, if that is purely in autism, sensory difficulty, no amount of exposure response prevention is actually going to work to systematically desensitize. We can't do that, and it's cruel. However, if it comes from a phobia, if it comes from OCD, systematic desensitization does work. So what we have to do is we have to get surgical, involve the child, and really work to understand what lies in each category.
Okay. Someone asks, how does OCD change as children get older?
Great question. It goes all over the place. So at this point, I'm 41. My OCD onset was at age 7. My OCD has jumped around with every single theme. I've had all sorts of compulsions. In the OCD world, this is known as morphing. So it doesn't happen to everyone, but it happens to most of us that we seem to simply outgrow certain fears and certain compulsions, and we move on to something new. So with younger children, elementary school children, we see a lot of separation anxiety, fear of the dark, fear of something terrible happening, superstitious fears, fear of the unknown. As kids get into middle school, there's a lot more of that social phobia. There's sometimes fear of getting one's period, fear of puberty. There can be a big uptick of OCD around puberty. especially in females, with born female kiddos and adults, it really depends on the hormonal fluctuations in the body. And that's one of the reasons why there can be surges during times like puberty. OCD in college can lead to not being able to go to classes, to dropping out. OCD that is untreated when a child is in their early 20s can sometimes lead to the phenomenon of failure to launch, which I call the highly dependent adult children community. That is kind of the grown-up school avoidance kiddos who most likely have developed agoraphobia, which is a fear of the panic, which makes you largely stay home and hide rather than go out and live your life. So OCD can show up very differently. And just because a child has outgrown a certain compulsion or moved on doesn't mean that the OCD isn't there.
Do people usually move from one compulsion to another? If they've sort of battled one, does it sort of morph into another?
Oftentimes, it's sort of the thing that tends to morph is the obsession, and then the compulsions are a response to the obsession. Mm-hmm. So, for example, I used to have an obsession with being seen as perfect. And so the compulsion was, ironically, selective mutism. So because I was afraid that if I spoke, I would speak badly, this would have been a huge exposure for me, kind of at any point in my life until the last 5 years. But I was convinced that I would seem more perfect if I was silent. So that was something that I, experienced from 7 to 11. But then around 11, I started to get obsessed with my body instead. And then a lot of the perfectionism, a lot of the compulsions started to be around food or over exercise. So, it's the compulsions follow the obsession, but the obsession is really the root of the behavior.
Wow. Thank you for sharing that.
Mm-hmm.
Someone writes, I'm worried about the trauma that my child seems to be going through due to their OCD mm-hmm. and the long-term impact this might have on them. I was wondering what risks there might be.
Yeah, that's a very compassionate question. Yes, untreated OCD does cause trauma. It is a really difficult condition for some of us, for a lot of us. And so when people joke about I'm so OCD online, that's why those of us who are in the field get really upset at that, because it can be excruciating and it can be traumatic. And this child is really lucky to have a parent that recognizes that. That being said, the path is the same. The path still has to be exposure response prevention, moving through the fears to get control back of our lives. The major trauma that, I would personally share, and I like to share about my own experience of OCD because I think that it really helps give voice to it. But I most regret lost time. I most regret the time that I spent hiding rather than living. So as traumatic as it, was, and as difficult as it was to do those exposures and push myself out of my comfort zone, when I look back, I just wish I had done it sooner. So when we're choosing OCD treatment, we are choosing to have short-term distress, short-term discomfort in order to have long-term gain. And after everything is said and done, we can definitely do trauma treatment as well, because that is real and that also needs to be, held and treated.
Okay, wow. What are some common accommodations for OCD at school? Someone asks.
So this is a great question. And it's a very, very tricky one, because in the world of neurodiversity, accommodations, school-based accommodations are amazing. I myself have fought for many a IEP, many a 504. They are great for neurodiversity. They help us access the curriculum. However, for OCD, accommodations are actually not helpful. In fact, can be very harmful. The reason why is that accommodations tend to actually make OCD worse when we're being overly supportive of the child with OCD and, helping them avoid their stressors. We can actually be exacerbating the OCD. So the only school-based accommodations that I really support are ones that are temporary, that are meant to basically help the child be able to get back into school or get back into learning, but they do need to be reduced over time so that the child is able to continue to have that good window distress tolerance when they're at school. If we make school too nice for the OCD, basically, the misophonia kid eating in a separate room from the other kids, we are actually going to make it harder for the child to recover.
I have a question related to that. My son refuses to eat lunch because the cafeteria is quote unquote gross and not a place you'd want to eat. How do I handle this?
Yeah. So same thing, temporarily, we want your kiddo eating lunch. So temporarily, there can be some school-based accommodations so that he's not, incredibly hungry at school, but he does need to eat in a gross environment. We do need to create a fear hierarchy that slowly, compassionately exposes him to the gross, whatever that means. The gross might mean actual food issue, but it also might mean people. We have to really figure out why your son believes the cafeteria to be contaminated and work on helping him face those triggers.
Someone writes, my daughter constantly worries about having a heart attack. She has made us take her to a cardiologist who said that her heart is healthy, but she still has this fear, and it's so bad that she freaks out and cries sometimes.
Oh, yeah, poor kiddo. That's really common. That's in the health OCD category. Like I said, these kiddos that are afraid of cancer, an aneurysm, a heart attack is another big one. It's fundamentally a fear of death. And it's important that parents not be accommodating. Once you know that she does not have a heart issue, it's important not to be taking her to the doctor every time she has somatic symptoms, because the OCD can actually create those somatic symptoms. It feels real to her, but it is not actually anything wrong with her heart. It's really her belief that something is wrong with her heart.
Right. Okay. Someone writes, do you think there is a correlation between OCD and gaming?
So great question. I think that gaming addiction can actually be one of the compulsions, avoidance compulsions, especially with teens. I don't think all gamers have OCD, but it's certainly compulsive gaming, absolutely could be one symptom among many of OCD. I think addictions in general, substance addictions, gaming addictions, all sorts of addictions can actually be symptomatic of a bigger avoidance of a fear. So I think that it's definitely worth investigating.
Someone asks, is there a particular age at which it's best to diagnose OCD or when these symptoms occur?
Yes, I would just take someone in for an OCD specialist whenever you start to see those symptoms occur. Most kiddos have onset around 7 years old and then a big surge around puberty, like I said, but I have seen OCD in toddlers as well. It's very difficult to treat with exposure response preventions before the age of 5, but there really is no age that is too young to diagnose and really like start working on these issues.
Okay. Our last question is, my son takes screenshots of his iPad every 2 minutes while he's watching a movie on the iPad. Is that a tic or OCD? Also, he doesn't want to throw anything away. He likes to keep everything, including labels, receipts, tags, and so on.
Yeah, so it does sound like probably OCD. What your son is doing with the screenshots is something called digital hoarding, which is related to the physical hoarding that you're seeing in the inability to throw things away. I would definitely get him screened for OCD.
Okay, excellent. Natalia, thank you so much for joining us today and for sharing your expertise with our ADHD community. We appreciate it.
Thank you so much. I really appreciate people coming and listening. And please follow up with me. I just really want to help anybody who doesn't have an OCD specialist local to them.
Wonderful. And thank you to today's listeners. If you would like to access the event resources, visit ADDitudeMag.com and search podcast 526. The slides and recording are posted a few hours after each live webinar. If you're listening in replay mode, simply click on the episode description. Please know that our full library of ADDitude webinars is available as a podcast. It's called the ADHD Experts podcast, and it's available on most streaming platforms. We hope to see you again next week for our free webinar on DBT, or dialectical behavioral therapy for adults with ADHD. Make sure you don't miss future ADDitude webinars, articles, or research updates by signing up to receive our free email newsletters at ADDitudeMag.com/newsletters. Thanks, everyone. Have a great day.
Thank you. Bye.